Assalamu alaikum and good evening, everyone. Welcome again to the series of ECG sessions or symposium. This symposium have been happening over the last 2 years, quarterly. Dr. Sharif Bakir and myself have been putting it together and bringing it to you in the form of practical and to the point teaching of ECG. We're very practical. There's not a lot of didactic in these sessions. Then that's our objectives. This symposium is going to be a quick introduction, and then Dr. Sharif Bakir is going to give you a practical approach to read an ECG. So you can use this approach or you can have your own approach, but you have to be systematic. This is the number one advice. When you're reading a 12-lead tracing, you have to be systematic in reading it. Then what we will do is we will go over cases and over a lot of tracing tonight. And we'll try to go to do as many tracing as and 12-lead ECGs as possible, so we can cover more material. The focus, of course, is going to be STEMI, either recognition or risk stratifying or understanding the complication of STEMI from the ECG. So it's going to be a quick talk by Dr. Sharif, and then the cases. The cases. After that, we have a 10-minute quiz that will include 10 ECGs, and you are expected to read an ECG over 10 minutes, or sorry, over a minute every ECG. And at the end, there's I think, a prize for the winner, and that's, I think, a voucher from our colleagues. I don't have the details of that voucher, but it's a good price. And our objective out of this is to engage more people so we can get to reach more people and teach them the ECG because of a lot of reasons. I'm going to share you the objectives of why we're conducting this symposium. So this symposium, the reason is all of us know that ischemic heart disease is the leading cause of death. Most of the people who die of coronary heart disease and ischemic heart disease. We have to identify these patients. We identify them early, we save lives and we reduce the mortality. So reducing mortality is by diagnosing these patients early and giving them treatment early. In patients with ischemic heart disease symptom, 12-lead ECG recording. Interpretation is indicated at the point of first medical contact. So if you don't interpret this ECG and you don't diagnose it, you're not going to act. And if you don't act, usually the mortality is very high. So the diagnosis is missed and the patient is sent home because of that, then mortality is about 50%. If the patient is admitted and taken care of and went for primary PCI, their mortality is very low, down to almost 4 or 5%. So you save a lot of lives if you identify the patients at the right time. To give you examples of cases that did not have a 12-lead ECG and that led to a catastrophic outcomes, either a death or myocardial infarction that is not diagnosed and not treated. So the first one is a 42-year-old smoker presents with upper abdominal pain. This is his vitals. So 42 smoker with overweight, and he had a blood test in the emergency department where he presented to, and unfortunately he was assessed as a dyspepsia or diagnosed as dyspepsia, given a proton pump inhibitors, and was asked to return back if he got any symptoms. ECG was not done. What happened to this patient? This patient presented the same day, late night, 12 hours later, with a cardiogenic shock with this ECG. ECG now shows massive anterior lateral ST elevation myocardial infarction. Usually such a presentation or anterior STEMIs, especially if they're large, cover a large territory. They end with a cardiogenic shock, and cardiogenic shock carries a high mortality. This patient unfortunately died. An ECG earlier could have saved his life. Now let's look at the second ECG, or second case, 62, hypertensive, diabetic, neck pain, shoulder pain. Now, what I'm presenting here is epigastric pain, neck pain, shoulder pain, and those are atypical presentations, atypical presentation of MI or acute coronary syndrome. Unfortunately, this patient did not have ECG done, and he was assessed or treated as an arthritis, given NSAID, and was also asked to return back if he got symptoms. This patient came back with this ECG, diffuse ST changes and TOS changes, and he had a very high troponin, and he was lucky he survived. So patients who present with acute coronary syndrome, usually they present with chest pain, but also a good number of them will present with the neck pain, epigastric pain, shoulder pain, and arm pain. So make sure your level of suspiciousness, especially on those with risk factors and patients who are potential to have a coronary disease, your suspicion should be high, and you should do a 12-lead ECG. So ECG is important in identifying and also risk stratifying patients, and we'll show you a lot of ECGs tonight. Competency is very important. You have to. A lot of people think that they know how to read, and fortunately, you know, you will be surprised when I show you how the competency of staff. This slide, and this is going to be the last slide in the introduction, just to tell you that there is a gap. There is a gap in diagnosis, in the knowledge of our colleagues, and either it is residents or fellows or consultants. And this slide shows you that the light, very, very light blue is residents, and the second color, or the blue, fair blue, is fellows, and then the consultants at the dark blue. And look at the diagnosis. The upper row is sensitivity, and the lower row is the specificity. And you can see that only 60 to 80% of the reads are sensitivity. So it's the reading is not very, or the interpretation by physicians is not 100% in this case. So there is a good number of cases that can be missed, and those are all STEMIs in this study, which is published in the Journal of American Heart Association. And also specificity, of course, is good. Once the patient is or the physician suspects something, usually they can be more specific. So this is the summary of the quick introduction, as I say, and to show you that there is a gap in our knowledge. We have to admit that. And this gap, if we don't fill it and we don't fix it, the price is death or myocardial infarction, as we saw in these two cases. And I have a lot of cases. Recently, I had a patient who presented very late. ECG was not done till the 4th day. Now I'm dealing with this patient sitting in the ward with a bad heart failure, and because he didn't have the ECG and he was not treated timely. So thanks. I'll get to Dr. Sharif, and Dr. Sharif is going to share with us his slides. What we will do now is, of course, Dr. Sharif Bakir is a consultant cardiologist, and he practiced at the Heart Medical Center, Kids Heart Medical Center, and he is a very active cardiologist, and he's going to share with us his approach to read the 12-lead ECG. So, and then, of course, you have to have your own approach, or you can adopt Dr. Sharif Bakir's approach, and then we use this approach to read the tracing during the night.
Dr. Zubeidi, you can hear me and you can see the screen?
We can.
Okay. So, as Dr. Zubeidi said, myocardial infarction don't all the time depend on the symptoms. Yes, symptoms have to be taken in consideration, but sometimes also the way the patient have been presented. I will not take too much on this, Dr. Zubeidi have been said, but to tell you that there are a lot of differentiation on the presentation, also depending on the age, sex. Some people, for example, old age, they can come with epigastric pain. So When we said ECG, we have to know that there is how to interpret or how to introduce or how to read the ECG. Usually, it is better to have a scheme in your mind, and based on the scheme you applied every time. When you see the ECG, every time you have to apply this scheme, which is consists of why we should have a scheme, because why we need any test for any investigation. First, because I want for the diagnosis and also for prognosis. So when I interpret any test, I need it for diagnosis and prognosis. And also I need it for follow-up, because I want to see that what I am doing and I want to follow up what I am doing. So I need a test which is high sensitivity and high specificity. And I think the ECG is one of the rare tests that can apply us with all of this. So let us return back to what I am trying to tell you about introduction. First, you have to put a scheme in your mind, which is either rate, risk, axis, interval, segment, and others. If you put in your mind this scheme, automatically your brain will automatically, once you look to the ECG, you will immediately, you'll find your brain go to this systematic. This is very important. If you want to put the risk before the rate before the risk, whatever, but put a scheme and try to follow on this scheme. So we have to know also, be aware, not every patient with acute coronary syndrome presented with the typical symptom. This is what Dr. Zubeidi was trying to tell you in the first two cases that he showed you. Also, you have to know the criteria of ST elevation. New ST elevation at the J point into conjunction lead. This is very important. Should be more than 1 millimeter in the leads, in the chest lead or standard lead, and 2 millimeter in the chest lead. I will try to show you that this is quickly, but you have to know that ischemia due to left main coronary artery disease sometimes presented with something very strange, which you find that the change will be in the AVR. So like this ECG. So if you find an AVR, ST segment elevation in the AVR, this is a very serious thing, because if somebody came with chest pain with ST elevation in the AVR, this is, you have to alert your brain immediately. This could be a left main disease. So this is one of the tricks you have to know. Remember, want to record additional lead. We have sometimes you have to do V7, V9 in the back. This is why, because isolated posterior myocardial infarction can sometimes you have to go to this lead. Also, you have to know that, remember when to record additional lead, we have to go to the right side, because sometimes you have to look to the right side infarction, especially in patient with inferior MI. This is very important. Sometimes you'll find somebody with inferior MI. We know that the inferior wall is not have a big part in the contractility. But if you find somebody with inferior MI and you find that he's in shock or he's in hypotensive, you have to ask yourself why. Why somebody with inferior MI have this? You have to ask for right ventricular lead, because maybe he have an he have an right ventricular infarction. So this is some tricks you have to look for. And when we said that ST elevation, you have to know where is the J point, and you have to look for that. So this is just a quick, this is normal, this is peak T wave, because we have to know also sometimes the only presentation of the myocardial infarction is a peak T wave. And Dr. Zubeidi in the next few slides, in the slides for the cases, you will find that he picked some of the cases with a peaked T wave. Also, the progression of the ST elevation, you have to know that you will do first ECG and then second ECG, third ECG, you will find there is a progression. Loss of the R wave, this is also very important. T wave inversion and T wave normalization in someone, you know that you have T wave inversion. This is also some trick to tell you that there is some ECG change. Also, we have to know that based on the location of the ECG, for example, V1, V2, V3, this can give you an idea about where is the occluded artery. This is very important. Sometimes what we said hyperacute, sometimes we said that T wave, which is winter D wave, which means hyperacute T wave with ST segment depression in precordial lead. Also, we have to some sign the people, some people who like the what is called Welling signs, or some people call pseudo-normalization like here. All this some trick to tell you how to look. When we said Welling sign, which sign that biphasic T wave in V1 to V3, typically an up-down T wave. This is in the pericardial lead, and this wave sometimes give you an indication of critical lesion. So the QRS complex waveform should be nomenclated like this. If we say it like this is R wave. If it's small like this is small R wave. QR, QRS, QRS, and the usually give the capital letter to the biggest one. And also we have to know that we have different shape of the QRS complex. So there are 10 rules for normal ECG. We said all the time, to know the abnormal, you have to know the normal. This is very important because you will never know the normal unless you know the abnormal. Or we cannot know abnormal unless we know the normal. So my advice, try to train your brain and train your eye to see the normal. So once automatically see abnormality, whatever it is, you will able to pick up. Okay, so rule number one. Rule number one, we said the PR interval should be 120 to 200 millimeter per second, or 3 to 4 small square. So this is to give you an idea about the PR interval, to know short or long PR interval. So rule number two, the P wave should be upright in lead 1 and lead 2 and in V2 to V6. What does it mean? Which means that in lead 3, you can have change in the P wave, and also in V1, you can have a change in the P wave. So the normal P wave, you have to be upright in this is yellow color, while the other, it can be changeable. Rule number 3, the width of the QRS complex. This is very important. The width of the QRS complex should not exceed 110 milliseconds or to be less than 3 small square. This is very important also. Rule number 4, the QRS complex should be dominantly upright in lead 1 and lead 2, the yellow one. So this is very important. And also the QRS complex should be having RS in V1 and QR in V6. This is very important. R, small r and deep S in V1, and the small q and tall r in V6. This is very important also to understand. Rule number 5, the QRS and T wave tend to have the same general direction in the limb, which means if the general direction like here, upright, the T wave will be upright. If the general direction here is inverted, the T wave and the QRS complete will be inverted. Rule number 6, all waves are negative except in lead AVR. In lead AVR, you will find everything is negative. P is negative, QRS negative, and T wave is negative. Rule number 7, this is very important also. R wave in the pericardial lead must go from V1 to V4. Like, why? Because we have the horizontal chest lead. Because here is V1 in front of the right atrium and right ventricle, V2 in front of the right ventricle, V3 in front, start to go to the apex, V4, V5, V6. And this is explained to you rule number 7, which means the R wave in the pericardial lead must go from V1 to at least V4. And in the same time, the S wave in the pericardial lead must go from V1 to at least V3 and then getting down. Rule number 8, this is very important. The ST segment should start isoelectric except in V1 and V2. This is very important. Why? Because not all the ST elevation in V1 and V2 represent acute myocardial infarction. So this is not to be misled by this. So ST elevation can be in V1 and V2. Rule number 9, there should be no Q wave or only small Q wave less than 1 small square in lead 1 and lead 2 and from V2 to V6. If you find any Q wave in this lead, this is to raise the possibility in your brain that this could be an pathological Q wave. Rule number 10, T wave must be upright in lead 1 and lead 2 and upright from V2 to V6. Also, the characteristic changes in acute myocardial infarction. ST segment elevation over the area of the damage, ST segment depression in the lead opposite to the area of the damage, what we call the reciprocal exchange, and pathological Q wave to be present if the myocardial infarction is start more than 6 to 12 hours, or previous infarction before, were reduced R wave over the lead which have been infarcted, we inverted T wave. So This is the first stage, occur in the early stage. You will find that in the lead facing the infarction, slight ST elevation, may be normal in V1 or V2, as we said. And then the Q wave, the pathological Q wave change start to appear. If you look before, there is no Q wave. Here, the Q wave start to be deep, at least now more than small square. The depth is occupied 20% of the R wave, appear usually few hours. If I start to find Q wave in the with ST segment elevation, this is tell me that this man or this female or male have started infarction few hours before. Then the T wave change, late change. If you find that the ST segment start to be depressed and the T wave start to be deep, if you look before, there is no deep T wave. Now it start to be deep. This is tell me now that I have part time have passed. And this is very crucial because now I am starting to have Q wave, which means I am start losing the myocardium. So also we have to know the left bundle. The left bundle and the anterior MI, sometimes they are mimicking each other. So as will be, we see with some of the cases with Dr. Zubeidi, we show it to us that sometimes that you can confuse if somebody have left bundle branch block, how to differentiate between left bundle and between anterior MI. There is some criteria of to be knowing where is the if there is any left bundle with infarction or not, but to be in the safe side, anybody with left bundle branch block came with chest pain, consider him as acute MI until proof otherwise. If you are going to remember the clue, well, never mind, no problem. Which means QRS and ST slope loses of the discordance. Usually in the left bundle there was discordance, which means the T wave is against the main deflection. If you find that the T wave now start to be with the main deflection, this is tell you that there is an anterior MI. But don't forget, left bundle branch block with MI with chest pain, this is acute MI, unless if you have a previous ECG telling you that the patient have left bundle from before. So electrocardiogram criteria for the diagnosis of MI in left bundle, as we said, criteria 1 millimeter concordance with the QRS complex, the ST segment, or 1 millimeter in the LAD V1, V2, V3, or the ST segment elevation is more than 5 millimeter in discordant in the QRS complex. Forget about that. The most important part is left bundle with chest pain. This is considered as myocardial infarction until proof otherwise. So ST segment elevation, T wave change, Q wave development, enzymes elevation, and the reciprocal change. This is all this give you the idea that there is myocardial infarction. The right bundle is different because right bundle does not mimic MI or does not hide the MI. This is very important to understand. So to summarize, forget about the axis because this is very easy way to look for the axis. We said all the time, we have right axis, normal axis, and the left axis. I will not take time for that, but to make it easy for you, if you want to look to the left axis, the normal axis is the lead one upright, AVF upright. If you want to look for the right axis, in the intermediate axis like this is the left axis also. You have to know that this is a normal, the right axis, and then the left axis. You will find that this is the left axis looking to each other, and this is, sorry, this is the right axis, and this is the left axis, abnormal left axis. I will not take time for the axis. We'll say anterior infarction, as we said, it will be take from V1 to V4, and then inferior infarction from lead 2, 3 AVF, and we have the lateral infarction, lead 1 and the AVL and the AVL, or from V5 to V6. So I will stop now and keep the screen for Dr. Zubeidi.
Thank you, Dr. Sharif. And so I'll go ahead and share what you know the cases, and then we'll just go over them one by one. Let me see ECG cases. Okay, it's coming. Oh. Hold on. Okay. So what we will be doing here now, it's 7:30. I know some places, if you are in UAE, definitely this prayer
Dr.
times.
Abdul Rashid,
Yes.
can you put it in slideshow mode, please?
Okay, sure. Sorry. So if you can feel free to go for prayer anytime, but we'll go over the cases now. And so we have, I think, about 12 or so cases, and then we have what we call the drill, where we'll go more faster. In these cases, we'll try to go a bit slower. And this ECGs is a mix. Some of them are straightforward, easy. And so we got a different complexity according to our audience. We have a spectrum of audience. Some of them, we have physicians and we have nurses. So we try to, to cover everything. And we're trying to cover also the basics. So the first case is, 64-year-old male diabetic smoker. So the right profile. This patient, if he presents with any kind of symptoms, as we showed you earlier in the, in the first slide, any symptoms from up here, from the jaw down to the umbilicus, please suspect a acute or cardiac event or coronary event. So this patient presents with chest pain, so it's typical. Sometimes chest pain, by the way, is not as you describe. So it's not chest pain. Some people may describe it as feeling unwell or feeling something in the chest. But so you have your level of suspecting should be high. So he presented to an MPCI hospital, and he got 30 minutes to reach a PCI hospital if he's diagnosed with an acute event. So this is his ECG. And as we talked now at the start, to read the ECG correctly, to identify your patient, you have to have a system. And our system, we talked today with Dr. Sharif, showed us his approach, and his approach is rate, rhythm, axis, interval, segments, and others. That's what he does. I do it differently. Everyone does it differently, maybe, but you have to have a system. So, Dr. Sharif, based on the way you approach, how would you approach this ECG?
So this case, for example, I want to say rate. What is the rate? If you look quickly, rate, you have to find the distance between. You have to show the distance between through.
I don't know if you see my mouse.
Yeah, to use your mouse. Okay, so you have
Can
to
you
do
see
distance
my
between.
mouse, huh?
This is the rate, and it is. You have to look P wave, and each QRS complex followed by P wave. So P wave, and then followed by QRS complex.
Those are P waves, yes.
So this means that already they have that the patient is sinus rhythm. So rate, rhythm, axis. As we said in the axis, just look to lead 1 and ABF. If they are look away from each other, this could be left axis, but you have to go to lead 2. If they are more than the S, this is normal left axis. So this means that now we're going to rate, rhythm, axis, interval. You have to look to the PR interval and the QT interval and to measure it. And then rate, rhythm, axis, interval, and others. What is the others for you? If you look, there is any left bundle, right bundle, branch block. And then, so for here, segment. What is the segment you look to here? To see the segment, is isoelectric or not? Can you point, Dr. Zubeidi, on where is the ST segment elevation here? You will see lead 2, lead 3, AVF. If you find ST segment elevation, lead 2, lead 3, AVF, what does it mean for you?
So this definitely is an inferior ST elevation myocardial infarction. Now, what do you think about these R waves, Dr. Sharif?
There is tall R wave here now in this you have to think about, and also there is ST segment little bit depression. So we have to think about posterior with the inferior. Sometimes you can have posterior and the inferior wall MI. This is, you have to put it in your mind. What do you think?
Usually the R wave, so this is an R wave and this is the S wave. The R wave usually in the V2, V1, V2, and almost V3 is smaller compared to the, to the S wave. So, and the transition, in lead V3, V4, usually both are almost equal. So here there's an early or dominant R waves and V2 indicating maybe there's a posterior infarction. Other reasons, of course, of this R wave dominance can happen, RVH and other causes. But
And
in
also,
this
Dr.
case,
Zubeidi, someone will say maybe left ventricular hypertrophy, but if we have left ventricular hypertrophy, we will not find it. We should expect in the other lead, we mean the V5, V6 to find also there is some S wave, something. But here is this is most likely inferior with the posterior MR.
definitely. So it's important that so this is one message, is very important, what is the definition of ST elevation MI on ECG. And the reason is, once you diagnose that, you need to treat your patient as early as possible. This scenario, STEMI, what we call a STEMI, is a time-sensitive scenario. So diagnosing it and responding to it and triaging your patient the right way is very important. So ECG criteria for STEMI based on the guidelines is ST elevation of more than 2 millimeter in V2, V3, or 1 millimeter in two other contiguous leads. So you need two leads that are next to each other to have an ST elevation. 1 millimeter is enough, and you're having it in V2 and V3, it should be more than 2 millimeter. Another STEMI mimic is left bundle branch block. So a left bundle branch block, you may not be able to diagnose STEMI, but every left bundle branch block should be considered as a STEMI till proven otherwise. Importance of having an old ECG with the left bundle branch block is key. So if you can compare an old ECG, if it's new, then treat it as a left bundle branch, as a STEMI. So this is the definition of STEMI, and the next scenario will show you the atypical scenarios of STEMI also. This is a second. Any comments, Dr. Sharif, before we move to the next case?
What you said is exactly what we said in the introduction. Try to be systematic. This is very important. I will not repeat it again, but you have to be systematic, which means put a scheme in your mind. And as you said, the most important also, the left bundle. If somebody came with chest pain with left bundle, you have to consider it as acute myocardial infarction until proved otherwise, unless you have a previous ECG telling you that his left bundle is old.
Excellent. So the second case, male, 56, multiple risk factors. Already he got atrial fibrillation, and he presents with chest pain and shortness of breath. So chest pain, shortness of breath, but he all got atrial fibrillation. This is ECG. What do you see? So AFib. So now the ECG is a bit challenging, but go systematic. A lot of waves here and there. So Dr. Sharif, so previous history of atrial fibrillation, he presents with a chest pain.
So this is very important, because here, if you go through systematic rate, if you look to the rate here and the rhythm, you'll find that there is rate, it is variable, and the rhythm is not sinus, there is no P wave. So rate, rhythm, axis, here the same as axis normal, but as we said, it is not important in this one, but rate, rhythm, axis, interval. We look to the interval. Also, we'll find that the QRS complex are wide. So now you are having a wide interval. So rate, rhythm, axis, interval, segment. About the segment, you'll find that there is here what it looks like left bundle, and you have now left bundle with atrial fibrillation, and in the same time in the lateral lead here, sorry, the inferior lead V1 and lead 2, lead 3, and the AVF. So this patient, we have now a confusing ECG. So once you find something like this with wide complex and the changes in the ST segment and the patient with chest pain, what is, Dr. Zubeidi, what is the first thing to come to your mind when you see this ECG?
To me, this patient has atrial fibrillation in the background history. So he got AFib. And then I have a left bundle branch block that is slow in rate. And so the rate is one thing, but the left bundle, I have to, if I have an old ECG, as I say, then I'm going to treat it as, and there is a left bundle, then I may say, this is not something new. But if there is no old ECG, then this patient got a chest pain, got a left bundle branch block, we should be treated as an...
And also, Zubeidi, that if you look to the T wave, the upright of the so high, we said in the criteria to differentiate between left bundle or left bundle with acute myocardial infarction, if you find that the peak of the T wave is very high. So this is something we have to say that this is because most probably this is a myocardial infarction. But I don't want you to depend on that. chest pain with left bundle without any previous ECG, don't waste the time.
Yes. So I think that, and that point brings us to the Scarboza criteria, which I'm going to show on the next slide. That just make it simple for yourself. You know, if you want to use the Scarboza criteria, you're familiar with it, that's okay. But I would suggest, you know, chest pain with a left bundle branch block treated as an acute coronary syndrome and specifically as a STEMI till proven otherwise. So this is his ECG. So previous ECG didn't show a left bundle branch block. Of course, there was AFib at that time. As you can see, the rate was controlled, but there was no left bundle branch block. So this is a new left bundle branch block, and this patient got anterior ST elevation.
And also, Zubeidi, once somebody have a left bundle branch block, acute onset with the myocardial infarction, this is indicate a big area of jeopardized area. This is mean that the artery which is occluded is a very serious situation. This patient should not, he can go into shock at any time.
Usually left bundle branch block indicates an occlusion of left anterior descending artery. And this is the artery, they call it the widowmaker, because mortality is high with the left anterior with LAD. So atypical ECG presentations, we talk about left bundle branch block, and this is what they call Scarboza criteria, and they are described in the guidelines. This is the European Society of Cardiology guidelines. In ventricular paced rhythm, patients who had a pacemaker before, so if you have someone who had a pacemaker and the rhythm is paced, presents with chest pain. Also, you have to consider, you know, the ECG usually is not easy to diagnose a STEMI on paced ECG. So you have to take that ECG in a serious manner and treat it carefully as a STEMI till proven otherwise. Isolated posterior, of course, I mean, you need to compare with all the ECGs so you can tell. If you don't have an old ECG, I would take it, as I say, it's serious. This is for the paced rhythm. Now, isolated posterior MI may not present with ST elevation. We talked earlier in the first case that you have to have 1 or 2 millimeter ST elevation, ST segment deviation to diagnose STEMI, but also there is a STEMIs where the artery is totally occluded, but on the ECG, you don't have those ST elevations. And you may have ST depression, isolated posterior myocardial infarction, isolated ST depression more than 0.5 in lead V1 to V3, and ST elevation in the posterior lead. So usually we don't do standard posterior leads. Usually we do V1 to V6. So in the standard 12 lead, you will find ST depression only. So if you see ST depression in V1 to V3, think of posterior infarction and do posterior leads. And I'll show you on the next slide what does
Dr. Zubeidi, this is remind us with the first ECG shows inferior plus posterior.
Exactly. So we have a good, you know, we have a case that will show what does. And I have a question also from one of the audience here saying, you know, please show us a posterior infarction. And I think this is the case, you know. So ST depression, posterior infarction is important. The other one is when we talk about 2 consecutive leads. Here we can have an isolated lead with ST elevation, and that should make you worry and suspect a big problem or an infarction of the left main, or severe stenosis of the left main, or severe multivessel. And that's ST depression of more than 1 millimeter in 8 or more surface leads, or ST elevation in AVR. So ST elevation in AVR with diffuse ST depression, you know, you should start to think about left main or what we call a left main equivalent. So ST elevation in AVR associated with ST depression in other leads is very concerning, and it can be a typical ECG presentation of a very serious.
Before going to the case 3, everybody have to remember, you cannot diagnose myocardial infarction unless you have 2 successive leads. But the only exception is AVR. AVR, when you find AVR ST elevation, this is by its own, it raises the possibility of left main. But any other position, you should have 2 successive leads.
Right. So case 3, 44 male with hypertension and diabetes presents with chest pain, sweating. So typically you need an ECG. This is ECG. So let's go systematic on this ECG.
So again,
lead two tracings. The lead two.
rate, what is the rate?
So the rate is about somewhere in the 70s, 1, 2, 3, about 4 large boxes. So it's about 75 to 80 maybe.
Okay, rhythm.
But
How
it
we
is
know that
regular.
is
So he
P,
got a regular rhythm.
P and HP followed by QRS complex.
Yes.
Axis here, it is normal axis.
Normal
No.
axis, forward. Yes.
So
It's positive
segment.
in lead one, upright in lead one, and then in AVF it's almost.
Interval, the PR interval, QT interval looks normal. And then segment. What about the segment? Can you point, Dr. Zubeidi, on the segment?
So on the segments, so we got all the way. First thing we got the anterior leads, which is D1, D2, D3, D4, D5 is not so much, and D6. But then we have lateral, which is lead 1 in AVL. So this is an anterior lateral ST elevation. The ST elevation is more than 5 millimeter in multiple leads. And here also in this limb leads, the ST elevation is about 1 to 2 millimeter, 2 millimeter easily. Here is about 2 to 3 millimeter. So in the chest, in the limb leads, we have ST elevation in the lateral. In the chest leads, we have ST elevation in the anterior. So this patient got an sinus rhythm with the anterior lateral.
Another important point, if you look to the inferior, you'll find ST segment depression, which is called the reciprocal change, which means that you have in the opposite direction of the myocardial infarction, you have ST segment depression. This is very important because this is give you a confidence that this is the reciprocal change. Because someone maybe will say, oh, why not this to be pericarditis? For example, even pericarditis, you have ST segment elevation everywhere. But here you have what is called the reciprocal change. This is by itself a proof that you have an anterior-inferior myocardial infarction with reciprocal change in the anterior lateral myocardial infarction with the reciprocal change in the inferior lead.
Excellent. And the purpose of this is I want to highlight the importance of what we call localization of STEMI. So we talked about inferior already. We showed a case of inferior wall ST elevation that includes lead 2, 3 AVF. We talked about anterior, and either anteroapical or septal or lateral, and we showed those cases. And lateral, and we talked about posterior MI. Identifying, the region or the area indicates two things. One is the vessel involved. So that is of course, for the person who's going to do the procedure, the interventionist. But more important is the prognosis. And if you're dealing with an LAD or an anterolateral MI, is different than when you're dealing with the lateral or posterior. Of course, all of it is STEMI, but there is more risky MI than other. And anterior MI is usually more risky than inferior and more risky than posterior. But all of them have the same treatment at the end of the day. All of them should go to the cath lab and they should have their arteries open. But localization is important because, as I said, the prognosis.
Just to add one thing, Dr. Zubeidi, when we said the prognosis and risk, don't forget in the myocardial infarction, there is two risks, risk of the muscle loss and risk of the arrhythmia. This is very important. Yani even myocardial infarction in the first 24 hours can give the patient to develop VF. So this is very important. You have to take the patient quickly to the place where you can cardiovert him if you develop VF, not because of the muscle loss, but because of the electrical disturbance during, even if with the infarction, it is mild, like inferior. Also, don't forget that with inferior myocardial infarction, it can develop right ventricular infarction. It can develop shock. And if you start to use nitroglycerin, you make more shock. Here in the situation, you have to use fluid. So we have to be intelligent when you interpret the ECG.
Yeah, exactly. So because ECG is a diagnosis, and once you diagnose, this patient should be on monitor. One of the benefits of treating patients with the STEMI of CCU is this. You recognize the arrhythmia and you cardiovert or you shock this patient out of arrhythmia. When these patients are admitted to the CCU, the care is different compared with they admitted to a standard or a regular ward. If this patient MI was missed and he's admitted to the ward as a standard case, and he develops arrhythmia. The arrhythmia will not be recognized and he will not be shocked. Of course, this patient should be treated in the CCU for such arrhythmias. Case 4, 69, male diabetic smoker, presents with chest pain and sweating. So they did the ECG, and that's his ECG. So a bit complex now, similar to the one before. So obviously there's a severe bradycardia here, and
it is bradycardia, Zubaidi, or what is the cause of this bradycardia? This is very important.
So
rate, rhythm, axis, interval.
Exactly. So he's brady. It looks to me regular. I mean, the QRS complexes are marching at the same. I mean, I need to map them, but to me they look almost regular with one PVC somewhere here.
So rate. So, what is the rhythm here, Dr. Zubaidi?
So the rhythm here, I can't see P wave before every QRS complex. This one here, I don't see any P wave. Here, there's a blip here, but there's nothing here. And then there's nothing here. So to me, probably this is a complete AV block because the QRS complexes are regular. So this is an escape rhythm. And so there's definitely some high-grade AV block with maybe a sinus arrest. I don't know if I call these P waves, then maybe there's some still severe sinus bradycardia, but definitely there's AV dissociation. So there's a sinus node dysfunction and probably AV node dysfunction. And then of course there's ST elevation involving the inferior leads, which is lead 2, 3, and AVF. On the other side, with the chest leads, there is ST depression and then the R wave. Remember that this is also an escape rhythm, but probably high level escape rhythm.
And this is also important, Zubaidi. Why? Because what is the blood supply to the SE node and the AV node? From where the blood supply is coming? From the right coronary. And where is the inferior wall, the blood supply coming? From the right coronary. So somebody who develop inferior wall MI, this means that the right coronary is occluded. And this can explain why this patient can develop complete heart block also, because the same blood supply to the AV node and the SE node. So this is also need mathematical equation that this patient need to be, in spite that the infarction is from the inferior wall, and we know that the inferior wall does not have any support to the myocardium as a muscle, but now we have inferior, posterior with all of this arrhythmia.
Yes. Sorry, I'm going backwards. So exactly, I mean, you're totally right, Dr. Bakir. I mean, the RCA, so this is an inferior STEMI. And if you go back to the regionalization or the regions of the localization of the STEMI, we say this is the right coronary artery that's occluded, and RCA also supplies the sinus node and supplies the AV node. And those are the conduction, the key and the conduction system of the heart. So SA node and AV node are the generators of electrical impulses. And if they are ischemic, they may go slow, and that gives you the bradycardia, as we can see in this case. So dominant R wave. So this is an inferior, probably inferior posterior ST elevation myocardial infarction, complicated with complete AV node block, leading to such an escape rhythm. This patient should be treated with Dr. Sharif.
First, based on, of course, we have to have a pacemaker wire available because we don't know what will go the next. And we have to see the hemodynamics for this patient. Maybe have also shock because of the bradycardia, and also he can develop, we have to look to do right-sided ECG, maybe have right ventricular infarction also. So this is not a case that can be taken lightly. This is a very serious situation.
Yes. So I think, yeah, exactly. So this is a STEMI, and it's complicated with the conduction abnormality. So STEMI needs to be treated with a primary PCI urgently, and the patient needs to be stabilized hemodynamically and arrhythmia-wise with the pacemaker and maybe with inotropes. RV infarction, of course, right inferior infarction also can be associated with right ventricular infarction, and fluid should be key in treating such patients. And of course, avoiding nitrates is very, very important. So inferior STEMI complication. So RV infarction can happen. 40% of inferior wall infarctions also involve the right ventricle. The addition of right-sided ECG leads, as you talked about, especially V4R, will aid in that diagnosis. So right-sided ECG. Usually we do left-sided ECGs. In such case, you may request from your technologist or your nurse who's doing it or yourself to do right-sided leads. Bradycardia, if you're having a patient with an inferior STEMI, watch for bradycardias. They may not have it on the 12 lead, but shortly or within some time, they may go brady. So your eyes should be on the monitor at any time, because they can go slow, they can go any type of blocks, either a sinoatrial block or severe bradycardia, or they can get a high grade block defined as a second or third degree block, and seen in about almost 20% of acute inferior infarction. So it's 40% will have RV infarction, 20% will have AV blocks, a lot of them will have severe bradycardia. So inferior STEMI should not be taken lightly because there is a lot of complications.
And by the way,
those complications can be.
This heart block could be temporary. I mean, they can return back to sinus. This is very important because some people say there's some edema around the bundle from ischemia, whatever it goes, but at least you have to cover him most probably with a pacemaker wire temporary, and later on we'll decide what is the next step.
Definitely. Yes, of course. I mean, these patients, you need, once you get the blood flow back to the heart muscle and to the conduction system, especially very early, if the diagnosis is done very early and the patient is treated very early, the sinus node, the AV node, the myocardial muscle is saved, and the function of that muscle is saved, and function of those tissues, the AV nodes is, it doesn't get damaged and becomes scarred. Usually they recover, and that rhythm goes back to sinus normal rhythm. As compared to some patients who are late or who are not treated appropriately, they will go into a permanent complete AV block, and they will need a permanent pacemaker. Case 5, male, 39, hypertensive smoker, who family history of premature coronary artery disease. So he got multiple risk factors, chest pain and sweating. So this patient presented, I guess, to a very remote area, and he had a thrombolysis, and he was transferred. This is his ECG after he was transferred.
So again, Dr. Zubeidi, rate, rhythm, axis, interval, segment. So let us to go by rate. What is the rate here?
So the rate here is about 100, I would say.
Okay, so tachycardia.
Yes.
Okay.
So
And then rate,
rhythm is regular. Looks
so
regular. If you look at, the QRS complexes are marching regularly throughout the ECG.
Okay, rate, rhythm, axis is normal. Rate, rhythm, axis, interval, PR interval is normal. QT interval looks normal. So rate, rhythm, axis, interval, segment.
Normal, because you got upright here and upright here, so that's a normal axis.
The segment, interval is okay. What about the segment here?
So segments, ST elevation in these leads, okay, and ST depression here. So those are the limb leads. Let's go to the chest leads. Chest leads, we have ST elevation over here. And then here it's not, doesn't look so bad. And then here we got ST depression. So lateral, there is ST depression. Inferior, there is ST elevation. And then in V1, V2, there is ST elevation. Maybe there's RV.
This is very important ECG. Simply why? You have inferior and in the same time anterior. What is the blood supply for the inferior? Usually we thought about the right coronary. But what about the blood supply of the anterior? So this could be part of what is called the dominant left system.
It can be.
And usually these patients, it is very important that they can develop VSCD or something, because the septum is now taking all the blood supply from the septal perforator coming from the left.
So when you see ST elevation in anterior and inferior lead, think about either a LAD or think about RV infarction also. I mean, because here V3 is not involved, so I don't know. Maybe probably this is still I'm in the right RV infarction. But you're right, Dr. Sharif. If I see anterior, and I think we have an ECG somewhere here in our tracings that we're going to see is a lot of anterior ST elevations and then inferior. And that one is typical for an LAD that's covering the anterior wall, and then it wrapped around the apex, and it goes and supplies the inferior wall. So when it's blocked from proximal, it supplies the anterior wall, so it will cause an anterior infarction, and it continues to the inferior wall, and that will cause an inferior infarction. So anterior, inferior, that's a proximal LAD. In this case, I think I got a RCA, or sorry, inferior STEMI, that's suggestive RCA. And I think V1, V2 only elevation is not enough for me to say this is a lot of anterior. There's no lateral, there's no septal, and there's no lateral, no septal. So it's mainly V1, V2. So that's suggestive of maybe RV infarction. Let's see. I guess the message out of this is the RV. So if to confirm it, of course, I mean, this ECG is what we call standard 12 lead ECG. V1, V2, V3, 4, and 5, and 6 is the ECGs on the left recorded on the left side of the chest. So to confirm that this represents RV infarction, you have to do what we call right-sided leads, and I'm going to show you those leads here in this picture here. So usually the standard leads are here. I hope you see the mouse. If you want to go and do right-sided leads when you're suspecting RV infarction, then ask for these leads. Usually V4R is the best. If you can't do them all, just ask for V4R, and it got the maximum diagnostic accuracy. But if you can do the 6 leads, that would be better. So inferior STEMI, RV infarction is suggested by the presence of ST elevation in V1, as we saw in this case. This case was V1 and V2, the only standard 12 lead ECG. So, and the other thing is, if you see ST elevation lead 3 more than lead 2, then suspect also an RV infarction. So lead 3 more than lead 2. This ECG, ST elevation lead 3 is more than lead 2. That also gives you a suggestion that this is an RV infarction. This is another sign of RV involvement. So if you suspect RV infarction, go to the right-sided leads. You'll see it in V1 first, and the standard lead. Do RV leads and look at lead 3. If the ST elevation is more than lead 2, and that's suggestive of RV infarction. Okay. Dr. Sharif, Dr. Sharif, we'll move to this case 6. Any comment?
No, it's okay. But as we said, we have to be careful about the inferior infarction with the right ventricular infarction. You have to be careful inferior infarction if you develop something with the left system. You have to be more to do some mathematical equation in your brain to look where is the artery occluded. This is very important.
Excellent. Another case 6. So 56 female, hypertensive, smoker, family history of premature cardiac disease, and she comes with chest pain and to an MPCI hospital. She walks into the emergency department, and her past medical history is non-relevant. So what to do? ECG. So she got the ECG, and so what do we have there?
So again, Dr. Zubeidi, rate, rhythm, axis, interval, segment. Let us to go by rate.
So her rate, lead 2 is the best to go over the rate and the rhythm. And obviously she got a rate about 100 or so. I mean, close to 100, maybe somewhere between 90 to 100. roughly. So she's sinus rhythm, almost close to be a sinus tachy. And she got a regular rhythm. To me, those QRS complexes are marching regularly.
There is an important point with the rate. If somebody with inferior infarction, we usually expect to be bradycardia. But if somebody with inferior infarction to be tachycardia like this, and also we have to look to the T wave in the anterior lead. So we have to look again that maybe right ventricular infarction is part of the story, and this can lead to the tachycardia.
Exactly.
What do you think, Dr. Zubaidi?
Tachycardia, if you look at the Grace risk score, which is or TIMI risk score, any of the risk scores that look at, the chance of mortality or the risk of mortality in STEMI, usually tachycardia is a bad sign. So if your patient, if you have a case with STEMI, look at the monitor, and if he's running fast, if his heart rate is more than 100, this is a bad prognostic factor. So you should be rushing and carefully, rushing this patient to get his artery opened in the cath lab. And the patient should receive, of course, the aspirin, the antiplatelet, like ticagrelor or clopidogrel, loading dose, and so on. So treat them early, and because they're heading towards a cardiogenic shock. Tachycardia is a bad thing in anterior mind, or even sometimes in inferior mind. So this patient, so we say this is a regular rhythm. The rate is about 100 or so, close to 100, and he got an ST elevation. Oh, sorry, got the axis.
Rate axis.
Axis is normal. Upright QRS over here, and the intervals, they look fine. Okay. I don't have the ECG, the computer read here, but they look fine.
So now segment.
Segment, ST elevation in lead 3 AVF. I hope our audience are following us here. And then we have, so the ECG you're just talking about, Dr. Sharif. So a lot of STs here, ST elevation, hyperacute Ts. So such T waves, we call them hyperacute T waves, and there is a differential for those. So sometimes you see this for hyperkalemia and some other, intracranial bleeds and so on. But in this case, obviously, there's ST elevation and there's a hyperacute T waves involving the anterior leads and also the inferior leads.
We have now inferior plus anterior.
Exactly. So that's the case. So this patient got a sinus, he's heading towards a tachycardia, and his ECG shows ST elevation in the anterior and also in the inferior, probably indicating a very large left anterior descending artery. So, I thought of getting you this message out of the European Society of Cardiology guidelines, and this is very important for our colleagues who work either in the emergency or in the clinics. Remember that any patient who comes in or comes to you with chest pain, with gastric pain, or shoulder pain, neck pain, jaw pain, and he's at risk, you need to do an ECG, 12-lead ECG recording, and interpretation is indicated as soon as possible at the point of first medical contact with a maximum target delay of 10 minutes. So this patient should have their ECG within 10 minutes. It's not about sitting in there and waiting, and then they get their ECG. Once they come to a clinic, every emergency should have a protocol to identify those patients and to get them to get the ECG. So that's, I think this is a very important message out of the guideline. ECG within 10 minutes. But this patient obviously got an anterior and inferior ST elevation suggestive of a large left anterior descending artery. Any comment, Dr. Sharif?
No, it's okay. This is very excellent that we have to go through the guidelines, which is very important.
Exactly. I mean, I think, we see a lot of patients that gets a delay in their ECG, in getting the ECG. And I think it's very important to remember this. So it's not about reading the ECG, but also it's about doing the ECG at the right time. So case 7, Male 44, smoker of dyslipidemia. Comes in with a chest pain and sweating and dyspnea. Okay, so male 44, smoker and dyslipidemia deserves an ECG, of course, with any kind of symptoms, you know. So he had an angiography, but no detail in the past. What do you think about his ECG?
Again, Dr. Zubeidi, everybody, rate, risk, axis, interval.
So rate is about 75. I mean, here there's 4 large boxes. I would say 75. It's regular to me. The axis is normal, and it's upright lead 1 and upright AVF. And intervals, to me, they look fine. The segment, I don't see any ST elevation or ST depression anywhere, except here there's some sort of sagging STs, but not very impressive. So this ECG almost, I mean, still I would call it within normal. I mean, the R wave here is a bit slightly more dominant than I would expect. Maybe it indicates something, or just the positional position of the lead. So
very important, Zubeidi. Why? Now chest pain with ECG looks like most likely normal. Yes?
Yeah. Yeah.
So what is the next step?
So if the patient is, as I said, so let's go backward to the case. And the case here to me is, is a high risk. It's more, my suspicious is very high in terms of that this is acute Crohn's syndrome, or there is some sort of a coronary event, because he's male, middle age, smoker, dyslipidemia. He had an angio in the past. I don't have the details, but that makes me even more concerned. And then, he got a chest pain now with sweating. When the patient sweats, you have to sweat. You have to think of something serious. And sweating usually is not something easy, unless, of course, he's out in the heat. But if someone gets a pain and he's sweating, as they say, if the patient is sweating, you have to be sweating. So his ECG is not very suspicious when he arrived to the emergency. What I would do is I will keep him, I will observe him, and I will repeat the ECG. And that's what his ECG showed 30 minutes later, when he had a repeat episode of chest pain. So let's go over it, Dr. Sharif. Dr. Sharif? It sounds like I lost the... Is everyone hearing me?
No, it is mute. I'm sorry, I'm the one who was mute. Okay, so I'm saying again, okay. This is very important. Rate, risk, axis, interval, segment, others. So can you comment on the rate, Dr. Zubeidi?
Sure. I mean, the rate is about what, 1, 2, 3, 4. It's about 100 or so. 100 rate. So I mean, we don't, I mean, of course, I mean, we can do the measurements of the rate, but just for the sake of time, we're not doing a very precise, accurate.
So this rate. Around 80 beat per minute.
1, 2, 3.
Raise sinus.
Four large boxes. Sinus, exactly.
P followed by QRS complex. Rate, risk. And
then you got a PVC over here.
Yeah. Axis.
And the axis is almost normal. I mean, there's upright here, and the QRS here is small, but it's upright.
So rate, rhythm, axis, interval.
Interval. To me, intervals, that looks fine. Yeah. I mean, it's not.
Rate, rhythm, axis, interval, segment.
Segments. So segments, although so of course, I mean, there's obvious ST depression in these leads in V2 and V3, and some subtle ST depression in V4, 5. But then in V6, there's a pattern of, of what we call ST elevation. It's not significant. It's not the 1 millimeter, it doesn't meet the guidelines definition. But the pattern here in V6, the pattern in AVF, and also in lead 2 and lead 3 are suggestive of inferior ST elevation myocardial infarction. They, as I say, they don't, if I consider these as the isoelectric line, which is about 1 millimeter below the hard line of the ECG tracing, and I look at the ST here, it's about almost 1 millimeter. So
what about the V1 to V3, Dr. Zubaidi?
So V1, V2, V3, there's ST depression, and the R waves are slightly dominant now in those leads, suggesting maybe there's an inferior associated with this inferior, there is a posterior infarction.
So now we have.
So I think I would treat this patient, So he got a history, and he got suggestive of a high-risk patient. He had a previous angio, which we don't know much about. But then he got a chest pain with sweating. And then this is his ECG. I would treat this patient as an inferior STEMI, and I would definitely...
Inferior with possibility, high possibility of posterior, yes? Of
posterior, exactly. Inferior posterior myocardial infarction. To confirm that this is a posterior, I would also do a posterior leads. And I think I can show you here the posterior leads later on, I think in the next few slides. So inferior posterior, he should be taken to the cath lab for primary PCI after loading him with antiplatelet treatment and giving him heparin. Any comment, Dr. Sharif?
It's okay, but this is raised the possibility also that, as you said, it is very important that to do a second ECG. Don't anybody came with chest pain and you feel that there is infarction, don't depend on the ECG alone.
Yes.
This is very important.
Definitely. Before going to the next case, I suggest we go over some of the questions, Dr. Sharif. Okay. And here we have so let's go back. Great presentation. Thank you for interesting and fruitful. What about the significance of QTC in ECG? I think he's referring, this is one of our colleagues, he's referring to one of the early ECGs. And as the upper limit for male and female range between 440, 470, up to what extent we could use some psychotropic meds like haloperidol? Should we avoid it, reach 500 or before that? What intervention assessment from cardiology point of view is the next step? So he's raising question about QTC interval.
The corrected QT, you mean?
Yeah, and the corrected QT. So yeah, go ahead, Sharif.
No, I mean, it is depend on, because we have to understand, I mean, the question is acute myocardial infarction. The first thing, think about that you have to do early reperfusion. Early perfusion. I mean, the most important, the ECG is to help you to take the patient quickly to the cath lab to open the artery.
Yeah.
Once you open, many of the abnormality could be changed immediately. This is very important. What do you think, Dr. Zubaidi?
Exactly. So in the setting of acute ischemia, you can get prolonged QTs, and you can get Torsad multifocal ventricular tachycardia. So we see it in ischemia, in myocardial infarction, and usually they respond very well to opening the artery. So you have to open the artery. It's not about giving them all the different treatments, antiarrhythmics. These patients, they need their artery to be opened. Of course, I mean, you can, give some antiarrhythmic while you're getting the patient to have these arteries. Once you open the artery, the myocardium stabilizes, the electrical storm stabilizes, and usually they do well. Of course, in the non-acute MI setting, then this is a different story. I mean, long QT, and it's out of the scope of our presentation, but definitely it's important that, you correct the QTC and you avoid any drugs for those patients with prolonged QT, that it's congenital or it's related to other diseases, systemic diseases. You get to avoid any other factors that prolong the QT interval. But in the setting of acute ischemia, go and open the artery first, and treat the patient accordingly. If you got any arrhythmia, if you got a if he got a torsade shock and out of it, if he's hemodynamically unstable, or give him antiarrhythmic drugs till you get him stabilized. Another question: why tachycardia is bad for MI? Usually, sinus tachycardia is an indicator of a bad cardiac output. If you're having a person with sepsis, he will have a tachycardia. Usually, it indicates a bad sepsis. It indicates a bad MI. Tachycardia is a sign. It's a sign. It's an indirect sign of a bad thing happening in the body.
And also, Zubaidi, don't forget tachycardia is the first response to low cardiac output is tachycardia.
Exactly.
So if somebody with myocardial infarction with tachycardia, this is mean that most probably the jeopardized muscle or the muscle affection is now affecting the stroke volume. So the only compensatory mechanism of the body is to increase the heart rate to keep the cardiac output. So this is indicating that this is the myocardium is so extensive in the infarction, or at least big area of the myocardium. And this means that the heart needs the tachycardia to compensate for keeping the cardiac output.
Yeah, so you're totally right. I mean, the cardiac output, the part of the heart is weak now, is ischemic, cannot pump, low cardiac output. You got to compensate with tachycardia. During infarction, there is a hyperadrenergic state. The larger the infarction, the higher the adrenaline in the body. So it indicates a large infarction. So tachycardia is an indirect sign, but it's a good sign to tell you that this patient is not doing well. Inferior MI, I can't understand that. You need elevated. This is very, very important. Still I see this question, and it's very important. You need elevated enzymes in diagnosing acute MI. In STEMI, you don't need biomarkers, and cardiac enzymes are not important to decide the treatment. If you see a STEMI, take the patient to the cath lab. Don't wait for cardiac enzymes. Don't wait for cardiac biomarkers. For non-STEMI, yes, it's important that you wait for the cardiac biomarkers because they're diagnostic there. In STEMI, they're prognostic. They just tell you if the enzyme is very large or highly elevated, it indicates a large infarction. But it should not make you wait and delay the treatment of the patient.
Important also, Dr. Zubaidi, when you send the cardiac enzyme, it takes at least 1 hour to return back. So if you are waiting for the biomarker with somebody with ST elevation MI, this means that you are delaying him 1 hour.
Exactly.
So
unfortunately,
I don't look for troponin at all.
Unfortunately, Dr. Bakir, I saw people still waiting for cardiac enzymes and STEMI. This should be, order the enzymes, but you should not wait. Treat the patient. ST elevation, treat the patient. ST elevation, treat the patient. Don't wait for enzymes. Order the enzymes, and
yeah, this is very, very, because you are delaying 1 hour.
You're delaying a lot of time. A lot of time. Just act on them. Even your primary care, there's ST elevation. Put the patient in the ambulance and send him to where he can get his artery open, while the enzymes can come later on. Another question: can you please point out to the J point? I think we'll do that in the next few tracings. Is it important to order cardiac enzymes? Still, we're getting the same question. Thank you for the session. Why we didn't do echo after the first normal ECG? I think that's a good comment. Yes, if you have a normal ECG, probably you can do an echo, and that will help you. Or repeat the ECG to decide if the patient needs to go to the cath lab. But doing an echo sometimes in the acute setting, if the ECG is normal, if you have an echo facility next to you, you're in a tertiary center, you have someone who can quickly scan the patient, I totally agree. Yeah, that will help identify if there's an anterior, inferior, or lateral ischemia. Last question here. So do we need to do ECG for each patient presenting with epigastric pain, regardless of sex, age, or presented risk factors? Yes, epigastric pain is a very confusing pain. And I think, in the right profile, I would do ECG. We saw a lot of surprises out of this, and, ECG is available in a lot of places, and it's easy to rule out. It's a good test to rule out anything. I saw you at the start, the introduction, 42 years old, came with a
Can I add something, Dr. Zubaidi? epigastric pain, if somebody have epigastric pain also with the age, but if you do a pressure in the epigastrium and no tenderness, this is also carry. You have to reason your point. Why there is no tenderness? If epigastric pain, it is abdominal in origin, usually there will be tenderness. So this is also, but you have to respect, yes.
Yeah, I mean, see, clinical, clinical skills are very important. And we tend to use a lot of technology, but it's very important. History taking is very, very important in such cases. And but if you do suspect a cardiac, I think you got to do ECG. We saw in the first two cases, 42 years epigastric pain, but he was a smoker and family history, I think, and no ECG was done. He presented late night with cardiogenic shock and he died. So, people can be fooled, and still we see such cases regularly. So the take-home message out of this case, which was normal ECG, and then he had a, we waited and then repeated the ECG, and there was a STEMI. I mean, this text comes from the European Society of Cardiology guidelines, and what it says is ST segment depression or elevation or T-wave inversion increase the likelihood that the discomfort is due to angina or ACF. However, lack of these findings should not rule out angina. So normal ECG does not rule out. So remember, if you're having a normal ECG, don't send the patient home. The initial ECG has a sensitivity of only 20 to 60%. So there's a good chance you'll miss about 50 or more patients if you just depend on the first ECG. Of course, you need the clinical background also to decide. So again, another case, Dr. Sharif, male, okay, 48, dyslipidemia, smoker. And his father had a ischemic heart disease at the age of 50. Usually when I see family history of premature coronary heart disease, it makes me worried. So, but this patient already, he got the genetic predisposition from his father, and then he smoked, so he added insult to injury, and he's also high cholesterol. Now he comes with a chest pain, and that's not the wonder, chest pain with palpitation. So that's his ECG.
So again, Dr. Zubeidi,
So rate is regular, and the rate, sorry, is 1, 2, 3. So about a yes, 80s, 90. It's regular.
Risk.
It looks
Sinus.
regular to me. It's regular.
Regular sinus, P followed by QRS complex.
Exactly.
Axis.
Axis is QRS complex here is up, and QRS complex is up, so normal. So
interval, QT and QR looks, and PR looks normal.
The QT looks fine here, and also the QRS is slightly dilated, or sorry, widened, and the PR interval is okay. And so then the segments. Segments, obviously, the first thing is the ST depression. A lot of ST depression in B1, about 5 millimeters from here up to here. Again here, the same thing here. ST depression. Almost okay here, but ST elevation here. Slightly ST elevation. ST elevation.
Just for the question of the J point.
Yes.
J point, and you have to go 2 small square away from the J point to calculate the ST segment elevation or depression.
Yes. So J point is here. You agree, Dr. Sharif?
Yes. This is the J point, the connection between the final, the end of the QRS and the segment, the ST segment. This is the J point. You have to go two small square away to calculate the ST segment elevation and depression.
Then you move over here, and then that's where you decide this ST, this point, is it elevated or depressed? Elevated or depressed? And you compare it to the isoelectric line, which is what we call, this is a T wave, and this is P wave. The TP segment is the isoelectric, your reference. So compare here. So let's compare. This is what isoelectric line, صح, Dr. Sharif?
Yes.
And this is probably the J point over here, صح?
Yes.
Sorry, the J point is here, but this is the ST segment. And the ST point here is definitely elevated compared to the TP segment of the reference line. So the same thing, some ST elevation here, again ST elevation here. So lead 1, lead AVL, V6, that indicates lateral, lead 2, and lead AVF. Lead 3 is just, you know, a low amplitude.
By the way, lead 3, it is changeable with inspiration and expiration.
Yeah.
Sometimes inspiration or expiration can mask lead 3.
Yes. So lead 3 is you know, isolated changes only in lead 3 is not very specific, is not helpful in diagnosis. But
Yeah.
obviously this patient got a lot of changes, ST elevation in these leads, lead 1, lead 3, lead AVF, and lead AVL, and then down in the lateral, lower lateral. And
So
then
infralateral plus
posterior probably.
plus posterior. So where is the blood supply for this?
So this patient can be circumflex.
Yes, that's very important.
So so what they did in this ECG is we thought of posterior. So they went and did posterior leads. And these leads are, you see V4, V5, V6. This is not left, actually. This is the posterior leads, but it's not tagged proper. So this is the 7, 8, and 9. 7, 8, and 9. And you can see a lot of ST elevation in those leads, indicating a posterior infarction. So because of that, and this is how to do those posterior leads. You see the patient, you know, you stick the leads at the back of the patient below the scapula and into these different lines, you know, axillary line and scapular lines, and then they close to the spine. And those leads will tell you if there's a ST posterior infarction. So ECG changes in V1 to V3. We saw that. We saw ST depression. We saw upright T waves, and then there's dominant R waves more than 1 in V2. That one, those findings made us do the posterior leads, and we saw the ST elevation in posterior leads. So if you suspect the posterior stemming, do posterior leads. This patient got a lot of ST depressions, and that he was treated. Any comments, Dr. Sharif?
No, that's okay. So I have to know that if you imagine that V1, V2, V3 in the posterior MI, if you are take the ECG upside down, it will be like ST elevation. And if you take the paper and make it upside down, in the case of posterior MI, it gives you the impression of ST segment elevation. This is the idea about you. Imagine that you are seeing the ECG upside down in V1, V2, V3 in the posterior lead.
Okay. Before I go to case 9, I want to highlight a question here. From a private clinic, MI cases can be shifted by ambulance only if the hospital gives approval. Ambulance should be given instruction to shift the patient to nearest hospital at the earliest. I don't know, you know, what is meant by the question, but I think, you know, if you are in a hospital, you need to have a clear protocol to transfer your STEMIs. So you have to agree with any hospital to say, when you have a STEMI, that's a lead in the emergency, the chair of emergency department or the lead of the hospital has to have an agreement with the hospital that has a primary PCI upfront that, you know, if we have a STEMI, we want you to accept those patients. And I can tell you in Abu Dhabi, this is very straightforward. You have just to go and get an agreement and you will get it done. And if it doesn't happen, let me know. This is very straightforward. STEMI patients can be transferred to primary PCI sites, and primary PCI site in Abu Dhabi, in the Emirate of Abu Dhabi, is you know, these patients are given a priority. So you know, private clinic, please organize with your nearest hospital that has a primary PCI and have a protocol, clear for transfer protocol. Another question, Dr. Sharif, in ischemia or MI, always ST segment. So why ST? What is the ST? Thanks. Yeah, I think it's I mean, you know, ST segment is indicative of repolarization, and usually, you know, we get, you know, it's a very, you know, I guess, um, complex
This
to
is
discuss
this
it
is
now,
because
but
of the way of the
it's
travel
a
of the
sign.
yeah.
Yes.
So this is the ST. This is the first manifestation of the infarction because of the thickness of the myocardium. You have to know that this is myocardium start to be electrolyte disturbance, and this is which lead to the ECG change. So this is the myocardial loss. It's ST segment elevation. This mean ischemia. And then if you after that, if it is start to be necrotic, it will be the Q wave. So
Yes.
this is
So yeah, I mean, it is important to look at the segments when you're diagnosing either ischemia or infarction. Let's move to case 9.
ST segment mean injury of the myocardium. Yani so severe ischemia lead to start the myocardium to be injured. Okay.
Yes. Yes, of course. I mean, ST segment elevation indicates you know, an injury
of the myocardium.
indicates an ischemia. Case 9, obese female, 53, diabetic, dyslipidemia, hypertension, and she got AFib. She comes with epigastric pain and shortness of breath, and she presents to a primary healthcare center.
Again,
so rhythm is
rate is irregular.
It's a regular rhythm, so the rate will depend on the numbers here of the QRS complex over this recording, which is a 10-second recording, and I would say it's somewhere in the 110.
Yes.
Or so.
Around 100 to 110.
Yes. And then the axis is normal.
Normal, yes.
Yes. And
but the rate, sorry, you speak about the rate. What is the rhythm here?
The rhythm is irregularly irregular, which is atrial fibrillation, and that we got that from her history also.
Yeah.
So she's AFib, and the rate is slightly on the high side.
Yeah.
QTs and the rest
rate,
of
rhythm axis interval.
The QRS complex is not wide.
Yes.
The axis we say is normal, but there is a pattern of ST elevation, including V1, AVL, and V6, and also V5. And then there's ST depression involving V4, V3, V2, V1. So ST depression all the way here, indicating that maybe a posterior infarction, and then lateral, there is ST.
So lateral and the posterior.
And posterior. Exactly.
So what is the blood supply?
So I think this is an AFib patient who presents now with a chest pain, and she got a posterior or lateral and posterior infarction.
Yes.
So just one point of the arrhythmias that complicates MI. So MI can be, you know, one of the main things that we worry about when we treat patients with myocardial infarction, beyond, of course, saving the myocardium and opening the artery to minimize the damage to the heart muscle, is also to treat the arrhythmia timely. So you don't want to delay treating the arrhythmia because the patient can crash and can go downhill. And arrhythmias, you know, sinus bradycardia happen in 28% of STEMIs. Non-sustained VT is very common. About a quarter of the patient will get it. Sinus tachy, a good percentage of the patient will come with sinus tachy. AFib is about 10% of the patient will develop atrial fibrillation post-MI. I just had one also recently that developed it after we opened his artery, and he responded well. High degree AV block, about 5 to 10% will develop high degree. When we say high degree, we mean complete AV block or a second degree Moffitt's type 2. Sustained VT is about 2 to 4%, and sometimes it's difficult to treat. But the key, again, as we said early, is to open the artery, and then these patients usually they do well. VF, about 2 to 5% of the patients will have a VF. Of course, all this arrhythmia, it tells you one thing, very important. If you suspect an acute coronary syndrome, connect the patient to the monitor. That's the only way you will diagnose these arrhythmias. So, so that's the case there. Dr. Sharif, do you have anything to add?
No, it's okay. This is very important, as we said. But as you said in the beginning, also depending on the location of the where is the inferior usually have some bradycardia, some yani whatever. But it is give you idea about that arrhythmia should be careful about.
Dr. Bakir, a question: how can you calculate rate in an irregular rhythm?
Yeah, this is the usually the difficult question is coming from the atrial fibrillation. There are many ways, either to take 10 seconds, as you said, or you can to take at least 10 beats and then calculate between each beat and then divide it on 10. Everybody can calculate it is depending on how you can use it. But usually, if you have seen ECG for lot of time, your eye will able to calculate between, because you can take between one each RR and take, for example, 10 or 15 RR and then calculate all and then divide it on the number which you have been taken.
Okay. So, so you have a way to do it. It's, you either you count, what I did is I counted all the QRS complex quickly. So I got something around, I can't remember the number, but then you multiply them by 6. The retracing here is 10 seconds. 10 seconds, in 1 minute, you have 60 seconds. So multiply this by 6 and you can read about it. It's very important. We don't have the time to go to this detail, but it's a very important question to how to calculate the rate in irregular rhythm. What is your current strategy for stemming culprit vessel only or total revascularization? Still, most of the people treat the culprit vessel, and if total, same setting or stage during PCR index. This is a very complex intervention question, and usually we treat the culprit. Occasionally, in low-risk, straightforward cases, we do multi-vessel at the same session or during hospital stay. So this is a clinical question away from the ECG, but I think it's important. Let's go to the next case so we can get time. Case 10, 45 male, chest pain, 1 hour duration, vomiting. He called EMS and he had this ECG. So ECG shows
rate, rhythm, yeah, rate. What is the
rate?
Rate
is about 1, 2, 3. So what I'm calculating is the large boxes, 1, 2, 3. It's about 100 or less than 100, close to 100. And the rhythm is regular, except for this QRS complex that is indicates a PVC, and then
axis?
Axis is normal, almost normal. I mean, lead 1 is kind of equivocal or equivocal, but AVF is positive, so it's down, and so probably normal axis.
Interval?
And intervals are fine. I mean, the QTs are okay, and the PR interval is great. QRS complex is wide because if I measure the QRS complex from here all the way to here, that's more than 120 milliseconds, and the pattern is suggestive of right bundle bunch block. So because QRS complex is wide, and
a Q wave you can see in V1, V2, V3.
Exactly. So, and this is the question, one of the questions from our colleagues is asking, can you show me a Q wave?
Q wave.
So what is a Q wave? Q wave is a deflection just after. So you see a P wave, and then a QRS, sorry, a P wave, and then the PR segment or interval, this segment, and then usually what we have is a positive deflection, even a very little positive deflection. If you don't have that tiny deflection in any lead over here, if you don't see a positive deflection, a positive, here is slightly a negative deflection, here a negative, here is some negative, here are deep negative deflection, deep negative deflection, deep negative. Those are Q waves. So
the Q wave, Dr. Zubeidi, is the first negative deflection before the QRS complex.
Before the QRS complex. So that first negative deflection, we call it Q wave. So there's a Q wave here, that's a Q wave, that's a Q wave, small Q wave. Those are significant Q waves. So what is a significant Q wave?
It is more than small square in depth and small square in width.
Yeah.
So
in width, you need the one small square in width. Here we have about 1 small square. Some people say 30 milliseconds or less it's slightly less than one small square. Here, in a large square, we have 5 small squares. So the width, you need just one small square. And here we meet it. And then the depth, some compare it to the positive deflection. So if it's more than a third of the positive deflection, that is a significant Q wave. And I think these Q waves are significant.
So
These
this
Q
is
waves
all
are
this
associated
significant.
with ST elevation. So these Q waves are associated with ST elevation. And the point out of this ECG is, this ECG is sinus rhythm with right bundle branch block and ST elevation. So there is a right bundle and there is a ST elevation. And we saw the left bundle, and we learned that in left bundle, it's not easy to diagnose ST elevation. Yes, you can use Scarboza criteria, but it's not easy to diagnose ST elevation in left bundle. That's why we treat all left bundle as a STEMI. In right bundle, usually it's easy to diagnose ST elevation, and it does not mask the ST elevation as the left bundle. So this ECG shows you a right bundle. At the same time, there is ST elevation involving the anterior lead. So a STEMI in elevation in the setting of right bundle. The ECG criteria for a right bundle includes the following: QRS duration greater than 120 milliseconds, which we have. 120 milliseconds means 3 small squares. And then the pattern is V1, V3 of right bundle. And then slurred S wave in lead 1 and ABL. That's a right bundle. Unlike in the presence of left bundle branch block, myocardial ischemia and infarction can easily be detected on ECG when right bundle is present. So that's the lesson out of these ECGs. Right bundle does not mask your or doesn't mask the ischemia or the infarction.
Don't mask the infarction.
Exactly. Case 11, male, 42. We're close here. Male, 42, no risk factors, represents chest pain. So, being a male is a risk factor. 42, middle age. I would take chest pain seriously in this, although just male 42. Usually chest pain should be taken seriously. Okay, that's his ECG.
So again, rate, rhythm, axis, interval, segment.
So rate is about, so this is the QRS complex. Let me see it. And then, sorry. So we go 1, 2, about 3 small squares. Large squares. So that indicates maybe about 100. So rate of 100 per minute. And the rhythm is regular. Every QRS complex is
followed by
distance is followed by also a P wave, or every P wave is followed by a QRS complex, and all are regular. So sinus rhythm rate of about 100.
Axis.
Axis, the QRS complex here is small, low voltage, but it's positive and upright. And then here it's equivocal, so probably normal axis.
Normal, because if you look to lead 2, Dr. Zubeidi, the R equal to the S, this is -0. So it's okay.
Exactly, yeah. So it's kind of starting to head towards the left, but still not left. And then you got, what else?
Interval, rate, rhythm, axis, interval.
Intervals. Let's take this lead here. So PR interval is okay. QRS is not so wide. It's not wide. It doesn't meet any bundle branch blocks or so. And the QT interval is not prolonged. So, and then the STs, there's ST elevation in lead 1, the L, and then of course there's anterior ST elevation involving all the leads from V2 to V6.
Yeah, for the question was the Q wave here. If you look V1, V2, V3, there is small r. So this is not a Q. This is small r followed by S in V1, V2,
yes.
V3.
Yeah, exactly. So that's the small deflection. So this patient did not Q yet. So he doesn't have a Q waves in the anterior.
Failure of progression of R wave, but still there is R wave.
Exactly. So the R waves, as you can see, so if it's a positive deflection after the P, that's a R. This is a small R, but still it's an R wave. Here R wave, and then it kind of grows into the rest of the lead. So this patient presents with an anterior lateral ST elevation. This is the first medical contact with the long time, 82 minutes. So that's a good time. Usually this patient should be treated from first medical contact to balloon within 90 minutes. Any comments, Dr. Sharif?
No, this is very good, very important that even they have no risk factor. But by the way, when we said somebody have no risk factor, maybe he didn't know, he didn't check his LDL, he didn't check his blood sugar. So when you ask him, are you have diabetes? He said no. No does not mean that he doesn't have, because maybe he didn't check, because he's young. For sure he have some risk factor.
So,
So this is very important. When you ask somebody, do you have the dyslipidemia? He said no. Did you ask him the second question? Did you check your lipid profile? He will tell you no. So from where you know that you don't have dyslipidemia? Do you have diabetes? No. Did you check your blood sugar? He said no. So from where you know? Because he thought that dyslipidemia and diabetes should have symptoms. We know that dyslipidemia and diabetes have no symptoms. So this is very important also.
Just a couple of things here. I don't know if we should do more because already we are heading towards the end. Maybe we'll do this last case and then I will go to the question, answer and chat box and then we'll finish. So male, 64, diabetic smoker, chest pain and sweating. Presents to the emergency as a walk-in. So he got multiple risk factors. He deserves an ECG and that's his ECG.
So same rate, rhythm, axis, interval, segment, and the others if you have. When
Yes.
we state other, this means that complete heart block or anything of abnormality regarding the conduction.
So he got a rate of 1, 2, 3, 4, almost 5 boxes, so about 80, and then it's regular. Every P wave is followed by QRS, and there's ST depression involving the anterior leads with lateral ST elevation here, and also ST elevation in the inferior.
The inferior.
Inferior lateral ST elevation with maybe a posterior.
Posterior or reciprocal change, we don't know.
Or the reciprocal changes. And obviously he got a posterior and we showed this ECG before. Last case, 64 male diabetic smoker and chest pain that is presented to an MPCI hospital, 30 minutes to reach PCI capable hospital. That's his ECG. So
very important. Rate, rhythm, axis, interval. So what is the rate here? What is the rhythm here? This is very important.
Yes. So obviously at the start, I mean, the rate is not so regular. There's some pause here, but then if I look at the QRS complex across here, almost regular all the way through. And the rate of this QRS complex is about 1, 2, 3, so about a 90.
But in the first three, Dr. Zubeidi, first, second, third, there is some gap here between the second and the third.
Yes. So that indicates there's sinus node and AV node, there's some ischemia there. And that's why we have some sort of a brady. The other thing is
P wink back, this one, for example.
The P waves are not marching well with the QRS complex. So you can see here, there's a P wave, there's another P wave here.
And prolongation here, you see, for example, the third beat, there is P, and then the PR, then PR prolonged, yes. But there is no drop.
So this patient got an AV conduction abnormality. He got an ST elevation in the inferior lead 2, lead 3, and lead AVF. He got a dominant R waves or a large R waves in V1, V2, and V3, indicative of posterior infarction. So inferior posterior, when we talk about inferior, we talk about bradycardia and we talk about ischemia to the AV node that can give you such an ECG. So so again, inferior with AV node conduction. I just want to go quickly over the chat before we go towards the quiz. Please stay tuned. So someone talked about the clinical importance of clinical assessment with all these ECGs. Yes, of course. I mean, this is not the focus of our session here is STEMI or ECGs on acute coronary syndrome, but any ST elevation got a differential diagnosis. You have pericarditis, you have a lot of other reasons that can give you, aneurysm, maybe pancreatitis, dissection, aortic dissection. lot of other reasons that can myocarditis. So a lot of other reasons can give you this diagnosis.
Just one comment, Dr. Zubeidi, regarding the question about pericarditis. Usually pericarditis, we find ST elevation in all the lead, which is unusual to have obstruction of all the coronaries. So usually if you find ST segment elevation of all of the lead, which don't matching with any significant branches of the coronaries, or you find PR interval elevation or depression, this is point to pericarditis.
Yes. So that's, I think that's important, is you know, is to, you know, when you're seeing your patients, you're assessing your ECG, don't forget about the other reasons. Our focus tonight is ischemia and MI, but of course, I mean, other reasons and clinical history is very important. ECG differential is very important. Should we activate the cath lab in all left bundle branch block patients presenting with angina or chest pain, provided no available previous ECG? If I want to go safe, yes, I would say any patient who presents with chest pain and the left bundle branch block, I don't have an old ECG, I would take it seriously and I would transfer the patient to the nearest hospital where there is a cath lab. The patient should get his coronaries checked. If you have an echo, probably an emergency echo can help you differentiate it, because if the LV is moving very well, then unlikely this is a new infarction. But if you don't have the echo, you got to transfer the patient to a primary PCI site. Which dose of clopidogrel, 300 to 600, we load with 600 milligram. I think those are the kind of questions they have, and there's other lot of comments and thank you and so on. We appreciate your attendance and your thanks. Dr. Sharif, I think we're coming to the end, and to our colleagues, we have about 400 people tonight, and I think I'm going to stop sharing. And we will
you will not show the 10 quiz case. We have no time.
I'm going to move. Yes. So now this is I'm going to share with you the quiz. So quick instruction about the quiz, and let me see it. I just want to make sure I have the quiz here. I don't know whether I lost it. Okay. Yes. So ECG. So we have a quiz here for our colleagues, and I'm just having some technical challenge here to get that quiz up on the screen, and then we will share the instruction before we move with it. Okay. So this quiz. So we got another almost 5 minutes to go, but the quiz is going to be so quick instruction before you take the quiz. So this is a 10 ECGs. We'll do 10 minutes before we finish and we conclude. And of course, as we said, the organizers had a voucher for this for the winner, and there's 10 ECGs. Each one, you read the patient information in the header, and then analyze the tracing and choose the answer. A pop-up screen will come and you just select the answer that you think is correct. And then we will analyze the answers and get back to you with the winner. This is the 10 minutes exam. Every ECG is a 1 minute. Automatically, you will get to the next ECG. If you don't click your answer, you will miss that. So, you know, before the minute finish, make sure you select something. Otherwise, you will lose a point. So, ready? The control room, everyone's okay?
We're ready, doctor.
Okay. So I'm just going to do the counting here with the, the timer. So this is going to be a minute. I'm not going to talk. So breathe and select. Shortly, we'll move to the next. Shortly, we'll move to the next. Shortly, we'll go to the next. Five seconds. Mm. Five seconds. 5 seconds. Five seconds. Short, we go to the next. Mm. 5 seconds and go to the next and the last.
الو
Yes.
عشان بس انا في ميتنج هكلمك كمان شويه.
So I think we're done here with the cases, with the quiz. I hope everyone got it. I think we had a few people who did not understand the instruction and they were answering in the chat box. You know, we're already 5 or 7 minutes beyond our time. I'd like to thank you all for the participation, for being here. Tonight, we covered almost, I think, 30 ECG tracing between the quiz and between the cases and the start of the introduction and Dr. Bakir's tips and tricks or method of interpreting ECG. So we covered a good number of tracing. I hope this was useful. As I said again, our objective out of this is to share our experience. We want you to recognize if you face a patient with symptoms suggestive of acute coronary syndrome. We want you to get an ECG done. If you get an ECG done, you should be able to interpret it. At least we want you to be able to interpret if there is something that needs to be transferred to a place where the patient should get the right treatment. That's our key objective. We'll keep repeating this symposia, and we're looking for your interaction, your feedback to tell us how to, what will be more useful for you. I think I'm coming to the conclusion. I don't know, Dr. Bakir, if you want to add anything from your side.
We need their evaluation, to send us their evaluation, and also any suggestion for the next, symposium, which is very good.
Yeah.
We hope that to know what we should do, what we shouldn't do, and
exactly. I think that feedback is important. Thanks to everyone. Thanks to the organizer, for our colleagues from ICOM. Thanks to our sponsors, and thank you, Dr. Sharif, for your time. And thanks to our colleagues who have been part of this session and for their interaction with the cases. And see you in the next event, inshallah. Have a good night.
good night.